Welcome. It's October 21st, Thursday. This is Kim McCleary. I'm President and CEO of the CFS Association of America, and it's my pleasure to welcome our audience today to our 16th webinar in the 2010 series, and to welcome our guest today, Dr. Morris Papernik. Our topic this afternoon is comorbid conditions, the alphabet soup of CFS, and this is a topic that always generates great interest. I think this is our second or third, depending on how you would classify some of the past topics, on the types of conditions that frequently coexist or overlap with CFS. And we're delighted to have Dr. Papernik with us today. And just a few housekeeping notes. I know that about 60% of our participants today have participated in one of our earlier webinars, so we don't need to spend too much time on the orientation to our webinar software, but I did just want to offer a few notes. Dr. Papernik and I are in different locations, so we can't see each other, we can't see you, and you can't see us, but hopefully everybody can hear one another, and the technology will cooperate. We've had a little issue, so I'm going to be advancing the slides for Dr. Papernik, but hopefully that won't interfere with the presentation in any way. We also know that 50% of the registrants indicated in the little questionnaire that we had that they have CFS plus 1 to 3 other conditions, and 40% of the audience has 4 or more conditions in addition to CFS, which means there's a lot of comorbidity out there among the people who have chosen to participate in today's program. So we got a lot of ground to cover, and Dr. Papernik took our title very literally, and we're literally going to move through the alphabet and talk about a whole host of conditions, some that you've probably heard about through our materials and others that may be new to you. We did share the questions, some of the questions that came in during the registration process in advance, and we'll try to cover those topics as we move through. But there also will hopefully be time for questions and answers after the presentation. So if you use the little dialog box on your control panel that's on the right side of your screen, you can type those questions in. Those will actually come into me, and if it's something I can answer, I'll try to do that, and otherwise we'll just hold on to them until the end, and Dr. Papernik and I will have a little conversation at the end of his presentation. We are recording today's presentation, and the recording and the slides will be posted online within a day or two. We put the recordings up on our YouTube channel. We found that that is a more accessible tool than making a WMV file available on the website, and the slides will be in a PDF format so that you can look at those at your leisure. This format does not really lend itself to Dr. Papernik being able to address individual questions about symptoms, test results, or therapies. He is an MD, a practicing MD, but it wouldn't be appropriate for him to try to practice medicine on patients he hasn't seen before. So we ask you to hold off on questions that relate to specific doses or particular symptoms that you may be experiencing or test results that you need help interpreting. Those would be better handled with your healthcare professional. So without further ado, I'd like to introduce Dr. Morris Papernik. As I said, he's a physician. He specializes in internal medicine and is currently practicing in Glastonbury, Connecticut, in a physicians group that's part of the Hartford hospital medical system there. Many of you will know his name from his former practice of medicine in Chicago and also his participation in CFS research there. He was part of the team led by Leonard Jason at DePaul University that worked on the first community-based estimates of the prevalence of CFS. Some of you may be familiar with the history. CDC indicated this was a fairly rare disorder affecting 3,000 to 10,000 people in the United States, and it was Dr. Jason who created a different study designed to go out and look in the community and try to identify people that weren't already being seen by healthcare professionals, and that's what led to the higher prevalence estimate of 800 to 1 million Americans with CFS. Dr. Papernik is also a former appointee to the Department of Health and Human Services CFS Advisory Committee, and that committee met last week, and while we were chatting before the program began. I was filling him in on the meeting. So he is well familiar with a lot of the political and policy issues related to CFS, in addition to his tremendous care of many, many patients with these conditions. So with that, I am going to swap over to his slides. We were, as I said, having a bit of a problem with the broadcast earlier this morning, but I think I've got his slides up. Dr. Papernik, can you see your own slide now?
Yeah, I can see it.
Okay. Well, welcome to the program, and thank you for being here, and we look forward to hearing from you. Ready to begin whenever you are.
All right. Thank you, Kim. Thanks for inviting me to do this webinar. I believe it's the first one that I really have ever done. I've done a lot of talks to lots of different groups of people, but never really in a room by myself with a computer. Hope everybody's dressed. I'm glad we can't all see each other, so that's a good thing. And I also want to say that I think Kim and your CFIDS organization has done a wonderful job in doing these webinars. I think it's a good resource for patients, and I hope they're taking advantage of it.
Thank you.
I was asked to do this thing called the alphabet soup of CFS. And like Kim said, I did take it literally. And what I did was I said, okay, what conditions from A to Z have a comorbidity, either go with CFS or can be sort of secondarily look like a patient with CFS, things that we go through as physicians to make sure we're not missing anything else that could be causing fatigue. And fatigue, as you'll see through this program, is probably the common theme that relates all these conditions together. And while we go through my slides, which are quite simple in the way they're presented, I'll be speaking about the conditions. And if I think of something while I'm talking about it, I'll probably just bring it up even though it might not be on the slides. And I'll probably add some more conditions as they pop in my head as we go through the slides. So with that said, we'll go through the first slide. And the first slide will be the letter A, obviously. And as you can see, and these are all the slides are going to look similar to this with different diseases, obviously. The first one we talk about is Addisons disease. Addisons disease is basically a primary adrenal insufficiency. So we go back to 1991 with Dr. Dimitrak publishing a study looking at adrenal insufficiency in patients with chronic fatigue syndrome. He at that time did show that there was a cortisol deficiency in patients with CFS. It wasn't a significant or tremendous amount of deficiency, but it was enough in his paper to suggest that it could be causing fatigue. And it had to do with the HPA axis, or the hypothalamic pituitary adrenal axis, and he suggested that this whole axis is somewhat off kilter, causing the adrenal insufficiency. The adrenal insufficiency would then cause the fatigue, which then would be consistent with patients with chronic fatigue syndrome. Now, the problem with that study was that the treatment for those patients ended up being giving them steroids. And a lot of people didn't want to do that because of the concern about steroid use, especially in the younger population. Long-term steroid use can lead to lots of comorbidities in and of themselves. So a lot of people didn't adopt it, and a lot of people felt that it was somewhat controversial to see a patient with adrenal insufficiency just presenting as a patient with chronic fatigue syndrome, because the typical adrenal insufficient patient or Addison patient will have a lot of other issues going on besides just fatigue. Nevertheless, the study was repeated again in 1998 in the JAMA, where they actually showed the same thing, that there was adrenal insufficiency in this population. And in this study, they actually gave patients steroids to see if they would feel better on the steroids, and the patients did feel better on the steroids. Now, putting people on steroids is something that a lot of people will feel better with. Steroids is considered to be a happy pill because patients do feel better on steroids, even if they don't have chronic fatigue syndrome. Just patients just in general feel better when they're on steroids. This study, however, in the JAMA took that into account and felt that that variable was taken out of the equation and that these patients actually did improve on low doses of cortisol replacement. So lots of patients will come in complaining of chronic fatigue-like symptoms, and at times we will do either cortisol levels or we will do cortisol stimulation tests to show whether or not there is an adrenal insufficiency in that population, and depending upon the degree of insufficiency, may or may not put them on low-dose steroids. Next one will be autoimmune diseases. Now, autoimmune diseases is a very, very, very broad topic, and I'm going to go through a couple of them individually as we go through the slides. But for this slide, I was just bringing up the idea that autoimmune diseases can present with fatigue as their initial presentation. So when people go and see their physicians for the workup of fatigue, autoimmune processes are always a top consideration and should always be looked at and ruled out to make sure that the patient's not suffering from any other possible autoimmune disease. Anorexia, as we all know, is an illness where patients have a problem with their self-image and they appear to have an issue with gaining weight. So they tend not to eat as much, and this mostly has to do with causing fatigue via malnutrition or via lack of vitamin therapy, etc. With the criteria that we have with chronic fatigue syndrome, patients who suffer from anorexia or bulimia are considered to be an exclusionary criteria for patients with chronic fatigue syndrome. Obviously, anemia is a highly consistent and highly common cause of fatigue in patients, and so when we do our workup for chronic fatigue syndrome, we always include a CBC to make sure they're not anemic. Now, the anemia in and of itself doesn't have to show up as a significant anemia. In men, the hemoglobin is considered to be normal if it's anywhere between 12 and 16. In women, we look at 11.5 to 14. However, you don't have to be anemic to actually have a deficiency that can cause fatigue, and we'll talk a little bit about that later on the other slides. Next slide. So in B, the top one I put was brucellosis. I put that down because early on in the diagnosis and research on chronic fatigue syndrome, brucellosis was considered to be a front runner in for one of the causes of chronic fatigue syndrome. Now, brucellosis is an infectious disease which can cause fatigue, and that's one of the reasons why the people at that time considered this to be a possible cause for chronic fatigue syndrome. At that time, in the mid-'80s, we were looking for a infectious cause that can be that we could possibly pin the etiology of chronic fatigue syndrome on. It can present as weakness, it can present as fatigue and malaise, but usually it'll also have other issues like arthralgias, a lot of muscle aches and pains. There could be fevers, some swollen glands. So a lot of this sounds like chronic fatigue syndrome, and that's why a lot of people thought that, hey, maybe this might be brucellosis. But that didn't really pan out in the research realm of looking for possible causes of chronic fatigue syndrome. Bipolar disorder is, again, one of those things that could be a exclusionary criteria for chronic fatigue syndrome. Obviously, these patients can have depression, can have manic episodes, but a lot of them will present as fatigue, and the fatigue is due to the depression part of the illness. And that's why when I see patients with chronic fatigue syndrome, or they present to me for the first time, I always make sure I do a good history looking for any elements of depression, whether it be unipolar depression or bipolar depression. Unipolar depression in and of itself is not exclusionary to patients with chronic fatigue syndrome. In fact, most patients with chronic fatigue syndrome will have some element of unipolar depression, either it be secondary to their illness or their issues about not being as active as they used to be. So what I tell my patients is if you're not depressed, then you're probably crazy because you really should be depressed because anybody with chronic fatigue syndrome who is not able to function like they used to, it's a pretty hard thing to deal with. So that's, unipolar depression is not a exclusionary criteria, but bipolar depression usually is. And finally, with the B's, I put in bulimia, which again goes with the anorexia issue. But again, this has to do more with weight loss, nutritional issues, and because of the bulimic aspect, can also cause imbalances in electrolytes as well as liver function. Next slide.
Morris, you skipped alcoholism on A. Somebody just pointed that out to me. So if we could go back to that one before we move forward to C, that would be great. I'm afraid we'll forget it if we don't.
All right. Thanks for keeping me honest here.
One of the audience members pointed it out.
Alcoholism. Absolutely. Alcoholism obviously is a problem. It can cause liver toxicity. Liver toxicity in and of itself can cause fatigue with abnormal liver function tests. The excessive use of alcohol will cause excessive fatigue as well. It'll definitely cause cognitive dysfunction. And so I'm always concerned about alcohol in my population of patients coming in complaining of fatigue. It becomes part of the history. Do you drink? How much do you drink? As well as when I ask, do you smoke and how much do you smoke? So alcohol is a concern, and I'm always make sure that patients aren't drinking to excess. So we'll go to number C. The big C, i.e. cancer. We always look at malignancy as a possibility because chronic fatigue syndrome doesn't have a specific test as of yet, which we can say, aha, this is chronic fatigue syndrome. We always, as physicians, are always worried. Are we missing something? Are we missing something that's crucial that could be the cause of the patient's fatigue? The other side of the coin is, does chronic fatigue syndrome in and of itself predispose a person to developing certain types of malignancies? And I think the jury is still out on that. I don't think we have enough data on that, but it is a curiosity. It is an issue which we're always struggling with. And so when patients come in, we do a pretty good workup to be sure we're not missing anything. But also, during the intervals when I see my CFS patients, I'm always thinking the same thing. Am I missing something? And especially if the patient is not improving like I would want them to improve, I always say, well, maybe I should go over again in my head and go over again in the testing to make sure, number one, that we didn't miss something, and number two, to reassure myself that we're not developing into a malignancy elsewhere. Malignancies, don't show up one day. One day you have it, next day you don't. Malignancies are very subtle, and they are very slow-growing. So the initial phase of a malignancy may go unnoticed except for the symptoms. And the symptom usually is fatigue at the beginning, and then followed by muscle weakness and other types of symptoms. So we always worry about malignancy, and I think as a CFS patient, I always tell my patients to be also their own advocate. So if they're noticing something different, they should let the physician know about it. Candidiasis. Now this is a touchy subject. And again, like with brucellosis, early on in the disease education and in the disease discovery, a lot of people were looking for possible causes of this illness. And systemic candidiasis became a hot topic of the time. And usually this was back in the late 80s. And actually there were several books written on it and talking about the yeast connection and taking medication for candidiasis. Unfortunately, there really hasn't been any strong study showing the connection between this and chronic fatigue syndrome. There have been studies showing a disconnect between candidiasis and chronic fatigue syndrome by studies looking at using anti-candidal medication versus placebo in a patient who was presumed having chronic fatigue syndrome, and there was no difference in the outcome between the placebo patient and the anti-candida treatments that they had. However, there are people who swear by the fact that when they take their anti-candida medications, they feel better. There are people out there who also say when they take their antibiotics, they feel better. So while there's no definitive evidence, as long as we don't do any harm, in some patient populations, the use of anti-candidal treatments may be beneficial. Personally, I have not seen it make a difference. But Candida is a hot topic, and everybody still points to some of the early physicians claiming that there's a yeast connection in this population. The last C on the list is cardiovascular, which is a broad group of symptoms, obviously. But mainly, I always put it on there mainly because of the issue with some of Dr. Lerner's work out from Michigan, suggesting that patients with chronic fatigue syndrome might have an underlying cardiomyopathy. When a patient has cardiomyopathy, the ejection fraction or the pumping efficiency of the heart is just not working as well as it should. So therefore, the amount of blood that's pumped out of the heart with each beat is decreased. And therefore, the cardiomyopathy in and of itself will cause fatigue, will cause shortness of breath, can cause cognitive dysfunction as well. So cardiovascular issues do or can cause symptoms very similar to chronic fatigue syndrome. I had a patient who once came in with symptoms of chronic fatigue syndrome when he was basically in congestive heart failure. And we fixed his congestive heart failure. His symptoms had improved, but he still had fatigue. So that's the other issue that we need to consider also when we're looking at these illnesses. These illnesses can be comorbid with chronic fatigue syndrome. Some of them can, I should say, in that if a patient comes in and is in congestive heart failure and complains of fatigue, I fix his congestive heart failure, but his fatigue still persists, then he has two conditions. He has the CFS plus his CHF. And as you'll see as we go down the list, other diseases like this are very common. Next slide. So, and one of them is diabetes. Elevated blood sugars. A person who has diabetes which is not adequately controlled will be fatigued, will have cognitive dysfunction. So a diabetic who comes in and is not adequately controlled, I never give them the diagnosis of CFS until I get the sugars better and they're stabilized with their diabetes. Only then can I get a clearer picture of what's happening with their fatigue and their cognitive functioning. Diabetics can also have neuropathic type pain. They can have diabetic peripheral neuropathy. They can have tingling, numbness sensation in their hands and their feet. And these can sometimes be similar to a patient with chronic fatigue syndrome having myalgias and arthralgias as well. Sometimes they can be construed as a patient with fibromyalgia with their pain. Again, then we need to be sure that these patients are treated to the best that we possibly can with their diabetes, and only then can we say maybe they have CFS and or fibromyalgia on top of their diabetes. Depression is, again, one of those hot topics. We mentioned it a little bit before about patients who are coming in with depression. Does that eliminate them from having chronic fatigue syndrome? And the answer is no, as long as it's unipolar depression. And as I said also before, that patients with unipolar depression is quite common in a patient with chronic fatigue syndrome because, as you all know, having the illness, having the disability from the illness is depressing. And a lot of patients will develop a secondary or reactive depression due to the illness. Patients always tell me that I'm not really depressed, I am depressed because of the way I am. Treatment of the depression is part and parcel of the treatment of the chronic fatigue as well. So usually when we fix the fatigue, the depression usually lifts. Next slide. Ehrlichiosis, babesiosis, and Lyme disease. Pretty much I could lump together, but I tended to, since I needed another E, I put in ehrlichiosis. Ehrlichiosis, before I came out to Connecticut, we didn't see much tick disease in Chicago area. Unless you went up to Wisconsin or upper Michigan, Chicago area in and of itself was not a very tick-laden area. So I didn't see much of that. I moved to Connecticut where Lyme disease was discovered, and all of a sudden everybody's got Lyme disease. And I had to learn about this very quickly. And ehrlichiosis and babesiosis are part of the tick-borne diseases which we see mainly in New England, but it can be seen anywhere really around the country. Mostly New England and northern part of the country, there is a type of tick disorder that we can see also in the southern part of the states. And interestingly enough, Europe has a very, very high incidence of tick disease as well. And Lyme disease is very high on the radar screen in Europe also. So ehrlichiosis is one of those tick-borne diseases that we see a lot of, and when we test people for Lyme disease, we should also always check them for ehrlichiosis as well as for babesiosis. And what we'll see in these patients, again, similar to Lyme, we'll see these patients have significant malaise and fatigue, some headaches, cognitive dysfunctions, some mood changes, but they will also have usually some abnormal lab data, like increase in the liver function test. They may have a large spleen. They may have a significant anemia. So whenever in New England we're checking for patients with Lyme, we're also looking for ehrlichiosis and babesiosis. Endometriosis is something that we should consider. I put this in there, but it's probably more so for fibromyalgia than for chronic fatigue patients. Endometriosis patients will complain of pelvic dysfunction, pelvic floor dysfunction, pelvic pain syndrome, chronic pelvic pain syndrome, whatever you want to call it. Significant endometriosis will cause significant amount of pain, will interfere with sleep, and in that way can also be transferred into a person with significant fatigue, and thereby causing a patient to have a picture that might look like CFS and or FMS. Next slide. So FMS, fibromyalgia, as we all are aware of this illness, it's characterized by chronic widespread pain, and the pain has to be above and below the body, right and left side, and down the middle of the body as well. You have to have 11 out of 18 tender points to make the diagnosis of fibromyalgia. And just recently, about 3 months ago, Dr. Wolf published a new guideline for physicians to diagnose fibromyalgia to being an adjunct to the traditional diagnosis by using the 11 out of 18 tender points. His suggestion, which we've really been doing all along for the past 20 years, but his suggestion now in writing is to use more of the other complaints aside from pain. By that I mean looking for irritable bowel syndrome, looking for fatigue, looking for sleep disorder, non-refreshing sleep, all the things that we all look at in patients with chronic fatigue syndrome. But when a patient comes in with fibromyalgia, we have to realize that this is not just a pain disease. This is a disease that has pain associated with it, but it definitely has significant impact on the whole system, i.e., it's going to cause the cognitive dysfunction, the fatigue, and the myalgias and arthralgias. If you asked me the question 5 years ago, is fibromyalgia and chronic fatigue syndrome the same disease, I would have said probably, but different ends of the same spectrum of a disease. The patient comes in, complains mostly of pain, I would put them in the fibromyalgia category. Patient comes in, complains mostly of fatigue, I would put them in the chronic fatigue category. Now, In the past 5 years, there's been a significant amount of research in fibromyalgia showing that probably a divergence from that theory, that fibromyalgia is taking off on its own track, so to speak, because of the research that's been done, showing a definite change in the neurological pathways in patients with fibromyalgia as compared to the patients with chronic fatigue syndrome. So nowadays, when people ask me that question, is fibro and CFS the same disease, I'm not so quick to say yes anymore. Next slide. Gulf War syndrome. Gulf War syndrome is something that started after the Gulf War in 1991. Vets were coming back with symptoms very reminiscent of patients with chronic fatigue syndrome. They were coming back with cognitive dysfunction, low-grade fevers, myalgias, arthralgias, and, of course, significant fatigue and disturbed sleep. The etiology of Gulf War syndrome is still unclear. However, early on in the Gulf War syndrome, people were trying to ascribe its cause to post-traumatic stress disorder or too many exposures to these IEDs causing recurrent concussions, which could cause the cognitive dysfunction. But right now, Gulf War syndrome, I think, is very similar to chronic fatigue syndrome, and the treatment is basically end up being the same as all these other illnesses that we're looking at today. Next slide. If we look at chronic fatigue syndrome, there's always this worry, or there's always this issue about infectious causes. And as we said before, anything that causes liver damage will possibly cause significant fatigue. So patients with history of hepatitis or active hepatitis, whether it be hepatitis A, B, C, whichever hepatitis you choose, can all cause a fatigue-like syndrome with significant sore throat, low-grade fevers, cognitive dysfunction. Obviously, the acute hepatitic patient is going to probably present with other issues like liver enlargement, the jaundice, and other abnormalities in their blood tests. But nevertheless, as a physician, we always have to look and make sure that their LFTs or the liver function tests are normal. Otherwise, you got to start looking at the liver as a possible cause for the fatigue. Now, there are other causes of hepatitis. Hepatitis just means inflammation of the liver. It doesn't mean infection of the liver. So the most common thing that we think of is the infectious hepatitis. However, other hepatitis or hepatidities also exist, and they can include things like fatty liver. A lot of patients who I see with chronic fatigue syndrome, they may have elevated liver function tests, but they're not infected with any hepatitis virus. And we work them up and we find they have fatty liver. Medications can cause a hepatitis, which can then cause fatigue. So you got to be careful that we don't limit ourselves to just an infectious cause for the hepatitis. There may be other causes for inflammatory liver disease. Hypothyroidism is the really go-to illness when patients come in with fatigue. If I had a nickel for every thyroid function test that was done on my patients with chronic fatigue syndrome before they see me, I'd be pretty rich by now. I see a lot of thyroid function tests being done, TSH being done over and over and over and over again. Obviously, we want to make sure patients are not low thyroid. That's why people do the thyroid function test. The interesting thing about the thyroid is a couple of things. There are two schools of thought about the upper limits of normal for thyroid disease. If you look at the laboratory data that you get from the Quest lab or whatever lab you're using, it'll show you that the upper limits of normal for TSH is, and that's the test that we look at for thyroid, is 4.5. So that's one school of thought. The other school of thought, however, is that TSH should be no higher than 2.0. So when I see the patient coming in who's perfectly healthy, has no problems whatsoever, just coming in for a routine exam, and their TSH, let's say, is 3.5, I don't worry about that. However, if a patient's coming in for evaluation of fatigue and evaluation of chronic fatigue syndrome, and their TSH is 3.5, that's not normal. And so I put them on medication to get their TSH below 2, and if they still have fatigue, then it's chronic fatigue syndrome, assuming that they meet all the other criteria, as opposed to fatigue secondary to hypothyroidism. Now, since we're on the thyroid, there is this other condition which was coined by Dr. Wilson, again in the late 80s, which was termed Wilson syndrome. And what he suggested was that there is a defect in patients in chronic fatigue syndrome. The defect is converting T4 to T3. You have to understand that T3 is the active hormone. T4 is the hormone that gets released from the thyroid gland that then gets converted in the body to T3. And then T3 becomes the active hormone. Patients can have normal-looking T4 levels, normal-looking TSH levels, even normal-looking T3 levels, but there is a dysfunction in the conversion of T4 to T3. Therefore, the T3 in the body is not up to snuff and is not in there in enough quantity. So therefore, in patients who we consider might have Wilson's, we consider putting patients on not just thyroid replacement, which is T4, but maybe also Cytomel, which is T3. There was a paper done about 4 years ago in the New England Journal of Medicine which suggested not only chronic fatigue syndrome patients, but all patients with low thyroid should be treated with 75% T4 and 25% T3. Next on the list is herpetic viruses, herpes. As you all know, in 1985, when this illness was first described, first described in our generation, I should say, the first thought that what the cause for this illness was Epstein-Barr virus, or mono. This virus is a herpes virus. And everybody was looking at EBV as the possible cause for CFS back in 1984, 1985. And interestingly enough, several other herpes viruses have come up as possible causes for chronic fatigue syndrome. Epstein-Barr virus was the first. After that came possibly even herpes type 1 or herpes type 2. Then came human herpes virus number 6 as a possible cause. Pretty much what we know right now is that Epstein-Barr virus is probably not the cause of chronic fatigue syndrome unless you had a documented case of acute Epstein-Barr virus and your chronic fatigue started right after that. I was involved in a study back in Chicago with Dr. Taylor looking at adolescents who developed chronic fatigue after they developed an acute bout of Epstein-Barr virus or mono, and lo and behold, there was a correlation between persistence of fatigue and the acuteness of the mono. Unfortunately, I see patients who are coming in with Epstein-Barr virus titers which are high, but it's the IgG type. Epstein-Barr virus and all viruses have an IgG and an IgM component. The IgM component is the acute phase. IgG component is the convalescent phase. So you'll see IgM in the first 3 weeks of the illness, then the IgM goes away, then the IgG comes on. And IgG will stay there forever. So when you bring in your Epstein-Barr virus titers and you show your physician, and he says, well, this doesn't really mean anything, what he's saying is that the IgG being positive just shows that you had been exposed to mono before. Interestingly enough, you don't have to have had mono to get IgG antibodies. Everybody in this country who grew up in this country, went to high school in this country, have been exposed to somebody in high school with mono. And just that exposure in and of itself can give you IgG antibodies and not necessarily even ever having come down with mono. So because of all that controversy with mono, most people now feel that the AEBV is not the direct cause of chronic fatigue syndrome unless there is some sort of direct correlation between the mono and the fatigue that followed it. HHV6, human herpes virus 6, is an interesting virus. It's another one of those viruses that is ubiquitous in the air around us. However, not everybody gets ill with this illness. There are people who had developed antibodies to HHV6, and the consideration or the theory is that HHV6 may in fact be a cause of chronic fatigue syndrome. We've seen HHV6 implicated in lymphomas. We've seen HHV6 implicated in some renal cell tumors. So it's an interesting concept. As of yet, we don't have enough to say that there was really a cause and effect relationship. Hormonal imbalances always need to be looked at, because if there is a significant change in any hormone we're talking about, if we're talking about thyroid hormone, we're talking about female hormones, we're talking about testosterone, those things can cause people to significantly change their mood. It can cause them to have significant fatigue. It can interrupt their sleep, non-refreshing sleep. It can cause myalgia. It can do all sorts of things similar to somebody who has chronic fatigue syndrome. So always, if a person is in that age category where I think there may be a hormonal change going on, I will definitely check that. HIV can definitely present as a fatiguing syndrome initially without any other symptoms. And usually we see a patient coming in, if they're coming in for the first time, they're coming with fatigue. They'll usually have some fevers, low-grade fevers. They usually will have diarrhea. They can have swollen glands as well, sore throats. So they can look like a CFS patient. But again, a good history and checking the labs will help you direct you to HIV or not. Next slide. Iatrogenic. Iatrogenic basically means that the medical community gave you the disease, meaning that we did something. Either the physician did, or there is a environmental issue, something that is creating fatigue within you. Usually it's due to medication. People can be taking certain medications, which obviously has fatigue as a side effect, and if you're taking too much of that, we look for any drugs that could be causing fatigue. Lots of times patients will come in and they've been given Ambien for sleep because they're not sleeping well and they're having fatigue, when the Ambien may be putting them to sleep, but then it's not giving them a good night's sleep. It's not giving them deep sleep, stage 3, 4 REM sleep. So therefore, the Ambien is part of the problem. Idiopathic basically means we have no idea why patients having their fatigue. You could have called chronic fatigue syndrome in and of itself an idiopathic disease because we still don't have a direct etiology for chronic fatigue syndrome. But idiopathic really means that there is no disease that we know of that's causing your fatigue. Immune-related or mediated basically goes to the autoimmune things that we talked about before, in that there is the body is responding to something that's causing the fatigue to persist. I like to tell patients that imagine that you were infected with a virus, and you got a cold and you had sniffles and all those things that go along with the viral infection. You have a cold, sniffles, sore throat, muscle aches and pains, but you also have this overwhelming fatigue, almost as if you just can't get out of bed if you got a really bad flu. So if you look at the body's immune system, it's basically set up with two different compartments for the immune system, and the energy system for the whole body is distributed through all our cells, including all the systems that work in our body, including the immune system. So if you got a body which is invaded by this virus, and you're putting all your effort into eradicating the body of this virus. All that energy is going to eradicate the virus, so that what you're left with is a very minimal amount of energy left, and therefore you become fatigued. The patient who develops chronic fatigue syndrome, and again, if you recall that a lot of the history that we see with patients with chronic fatigue syndrome, it's very, very common that they'll tell us that their chronic fatigue seemed to have started after they developed some sort of infectious process. What that tells me is that the immune system that is serving to fight off this virus or whatever this infectious cause was, even though they feel better without their sniffles, without their sore throats or myalgias and arthralgias, but their fatigue is persisting, but that tells me that there is still an immune-mediated process that's still fighting something that is still in the system. The next one is interstitial cystitis, or IC. I put this in there because this is a very, very common comorbid condition with patients with chronic fatigue syndrome. A lot of patients, also in patients with fibromyalgia, we see a lot of patients coming in and complaining of increased frequency of urination. The problem with this illness is that the bladder has a preponderance of mast cells in the bladder in this illness. Mast cells are responsible for releasing histamine. Histamine causes inflammation and irritation. So if you have a lot of mast cells or mastocytosis within the urinary bladder, there's a lot of histamine getting released in there, which is causing a lot of irritation, which gives you the sense that you have to urinate a lot. So patients with IC will urinate an awful lot, but not large quantities. They'll urinate small quantities but frequently. And they'll wake up at nighttime to go to the bathroom as well. They'll go to the doctor, and physicians will assume that they have an infection, and they'll treat the infection, which isn't really there. They'll have a lot of white cells, white blood cells in the urine, but they'll have the white blood cells because of the inflammation, not because of an infection, and there usually is no bacteria in the urine sample. So the history that I get with a lot of patients is that I've been treated over and over and over and over again for my urinary tract infection, and lo and behold, they don't have a urinary tract infection. This seems to accompany a large percentage of patients with fibromyalgia and chronic fatigue syndrome. Why that is, nobody really knows yet. However, if we look at the issue in the pathology of IC, again, there is this preponderance of mast cells in the bladder. Why? And one of the newer theories behind fibromyalgia is that there is a preponderance of mast cells in the skin of patients with fibromyalgia. And so therefore, there's an increased release of histamine in the skin of patients with fibromyalgia, which makes the skin hypersensitive to any sort of stimuli. Same thing that's going on in the bladder. So there may actually be a connection between the IC and the fibromyalgia by this mast cell connection. Next slide.
Dr. Papernik, could you add irritable bowel syndrome to your I list and tell us about that?
See that? Irritable bowel syndrome. So IBS, or irritable bowel syndrome, is something that's more typically accompanying fibromyalgia. In fact, Dr. Wolf, in his newer criteria, put IBS into the criteria for fibromyalgia. IBS is not a criteria for the diagnosis of CFS, but obviously patients with CFS have a large percentage of patients with CFS do have IBS as a comorbid condition. The etiology of IBS is still not understood. We do know there's a condition called visceral hypersensitivity, whereas if you stretch or have spasm in the intestinal wall, it will cause pain and it will cause symptoms of IBS. And so IBS is part and parcel of a large number of the symptoms that we see in CFS patients. The treatment for that is typically either using antidepressants or using certain medications depending upon whether or not your IBS is more constipating or more diarrhea. Next slide. Kidney disease, I put that in there because, again, when we look at chronic fatigue syndrome, we also need to look to make sure we're not having any patients who may have other conditions that can cause chronic fatigue. And chronic renal failure, chronic renal insufficiency is a very common cause of fatigue. Why it does it is most likely because when you have chronic renal disease, you have a decrease in erythropoietin production, which then decreases your production of red blood cells. And you don't necessarily have to be anemic, but it definitely causes a significant fatigue. And then the worse your chronic renal failure is, there's an increase in uremia, increase in toxins that will then cause cognitive dysfunction, and it could look like a person with chronic fatigue syndrome. So you got to make sure kidney functions are working, and that's easily tested on the blood test. Next slide. So we get to Lyme disease, and I touched a little bit on this before. Lyme disease is caused by a specific type of bug that is on ticks, and usually the deer tick. And again, New England, in the United States, New England is the big spot for Lyme disease, but it can really occur in anywhere in the country. But again, New England, southern states, Wisconsin, and Michigan are big places for Lyme disease. Europe, again, is becoming more and more of a vector for Lyme disease as well. These patients can have a history of a tick bite. Lots of times, as I've learned here in Connecticut, a lot of people will come in and not remember the tick bite, but they work in the woods a lot, and they come in with fatigue and myalgias and arthralgias, and we assume they were bitten by a tick. The traditional rash that we would see in a patient with Lyme disease is not necessary to make a diagnosis of Lyme disease. If you got the rash, and that's fantastic because the physician can then see it and say this is classic Lyme. But you don't have to have the rash to have Lyme disease. The treatment for Lyme disease is a very short window. The best time to treat Lyme disease is within the first 3 weeks of the illness. After you miss that window, the likelihood of improvement with therapy goes down the longer you've had the disease before getting treatment. Now, there are people out there who believe that long-term antibiotic therapy is useful for Lyme disease. There's an infectious disease doctor up in Massachusetts, Dr. Dantu, who is a big proponent of IV and or oral medication antibiotics for Lyme disease well beyond the original tick bite. And he's treating patients out for 2 years with these antibiotics. Interestingly enough, on a political aspect here in New England, here in Connecticut specifically, there was a battle between patients and insurance companies because insurance companies did not want to cover long-term IV therapy, IV antibiotic therapy for Lyme disease. And there was a big battle, and what they decided was that the researchers are going to go back to the table and look at the data again to see whether or not the long-term use of antibiotics in Lyme patients, chronic Lyme patients, is useful or not. Right now, the Attorney General has ruled that the insurance companies had to cover long-term antibiotic therapy until the study was completed. Do people develop chronic Lyme after they've had Lyme? And my answer to that is yes, but the symptoms are exactly like patients with chronic fatigue syndrome. The symptoms are of fatigue, cognitive dysfunction, a non-refreshing sleep, myalgias, swollen nose, low-grade fevers, sore throats, all the same thing that we'll see in CFS patients. So lots of times I'll tell my chronic Lyme patients to say, you can call it whatever you want, but the treatment's going to end up being the same. Lymphomas have to do with the cancer that we talked about before. There seems to be, in patients with CFS, seems to be an increased percentage of patients with lymphoma as compared to patients who don't have CFS. Nevertheless, there isn't a direct association to it, but again, it's one of those illnesses that we don't want to miss, and that it's always in the back of our minds as physicians. Lupus, systemic lupus erythematosus, goes under the autoimmune disease issue again, and again, autoimmune diseases can present just as fatigue, does not have to present with the classic lupus-like symptoms. However, the longer a person has their chronic fatigue syndrome without developing another illness, the less likely they're going to have the other illness, obviously. So lupus, if a person has an underlying lupus or other connective tissue or autoimmune disease, that other disease will usually present itself within 5 years of the diagnosis of the chronic fatigue syndrome. Patients with lupus will then obviously develop the typical lupus rashes, as well as organ damage and abnormal blood tests. But again, as far as the workup for patients with chronic fatigue syndrome, we always do the blood work looking for autoimmune diseases, and lupus is one of them. Next slide. MS. MS is a very, very common disorder that can present with fatigue. MS itself is not that common, but it is one of the more common diseases that present with fatigue as their initial presentation. And I have diagnosed multiple cases of MS who've come to me looking for a diagnosis of chronic fatigue syndrome, and lo and behold, they have MS. So I always look at MS, I always in the back of my mind is thinking about multiple sclerosis in a patient who presents with chronic fatigue. MCS, or multiple chemical sensitivities, is a comorbidity with chronic fatigue syndrome. Patients with multiple chemical sensitivities, is it due to the chronic fatigue syndrome causing the MCS? Is the MCS a possible trigger for the CFS? You can go both ways, and you can debate it both ways. What's the trigger for the MCS? Again, there is no specific data saying that exposure to any specific toxin is the cause for the MCS. However, these patients do exhibit significant amount of irritation or sensitivity to chemicals. Chemicals, whether it be perfume or stuff that we use to clean things with. So the MCS in and of itself, by the nature of its causing this sensitivity in the patient who has this, that in turn can create underlying fatigue as well. But what I find interesting is if a patient with MCS is not exposed to any of these toxins that trigger the illness, they still have the fatigue. So that raises the question of whether or not CFS is CFS and MCS are just comorbid conditions just living side by side. Muscle enzyme deficiency. Now, I wasn't a really big fan of muscle enzyme deficiency before I saw it myself. And sometimes you just have to see things for yourself in order to say, oh my God, that really is what's going on. And it applies to a patient who I had back in Chicago who had chronic fatigue syndrome, who one day came in and literally just couldn't walk. And I worked her up, and I couldn't find anything until I did so I finally did a carnitine level on her, and her carnitine level was like 0. We sent her for a skin and muscle biopsy, and she had no carnitine in her muscles. Carnitine is an enzyme that's used for muscle strength. And if you lack, obviously, that enzyme, your muscles are going to become weaker, and you're going to become more fatigued. And she had none of it in her muscles. And we replaced her with industrial strength of dosages of carnitine, and she made a dramatic recovery. So nowadays, I do check carnitine levels, and I have found other patients, not as bad as this one in Chicago, but other patients with similar types of carnitine deficiencies who do seem to improve if you significantly get the carnitine level up. And I think, Kim, you just put that migraine in there?
I did. I added one for you.
Good for you. All right. So Kim added migraine because she told me before not to forget migraine, and I forgot until she put it in there. Definitely migraine.
Teamwork.
Headaches, that's right. Migraine headaches are it's a comorbid condition. Again, one of those things that we see a lot with patients with chronic fatigue syndrome. I would say, well, looking at the criteria for chronic fatigue syndrome, headache is a criteria for chronic fatigue syndrome, but it's not just your occasional headache. It's the headache more like a migrainer will suffer from. Now, migraines are really diseases of young people. After the age of 50, patients really do not have migraines, and you shouldn't have migraines after the age of 50. If you come in after the age of 50 and you have a new migraine, that's a red flag. That's something we need to look at that, and why is that? But anywhere between the age of 15 and 50, it's a disease of young people, and we see it a lot in the general population. So one wonders whether or not it is a comorbidity or whether this is just a statistical phenomenon. With a lot of migraineurs, about 18 million in the country suffer from migraines. It's sort of like IBS in that, is it part and parcel of the disease itself, or is it because there's such a large statistical amount of people in the country who have that particular problem that if you take a lot of the chronic fatigue patients, more likely than not, you're going to see a lot of migraine headaches or IBS in that population. Again, it's an illness of the headaches usually affecting younger people rather than people over the age of 50. Next slide. Nutritional deficiencies. We talked a little bit about this when we talked about anorexia and bulimia, but we also have to make sure we understand that you don't have to be anorexic or bulimic to have nutritional deficiencies. So I always look at vitamin deficiencies, mineral deficiencies in my patients who are coming with chronic fatigue syndrome to be sure I'm not missing that. Patients may say, oh, I eat fine, but you find out they're so fatigued that all they're eating maybe is some frozen foods, and they're not even eating the meat, they're just eating the carbohydrates. A lot of patients want to be on a vegan diet or a vegetarian diet, and unfortunately a lot of patients who go that route, my daughter included, eat too many carbohydrates, and they're not getting the proper vitamins and the proper minerals that they really need. So I always look at that to be sure that patients are well nourished. Just because you're overweight doesn't mean that you're well nourished. NMH, or neuromediated hypotension, and I understand there was a webinar done by Dr. Rowe a while back, stemming from his study at Johns Hopkins, looking at patients with chronic fatigue syndrome who also had dizziness and had positive tilt table study tests. And the treatment for NMH seemed to improve the dizziness and the lightheadedness, and some of these patients also improved in their fatigue as well. Next slide. Obesity. So we just talked a little bit about nutrition, and obviously being overweight is going to impact all of our abilities to be effectively mobile. So if we are significantly overweight, we're going to have more fatigue. Significantly overweight, you're going to have more issues with sleep disorders. You're going to have more snoring. You're going to have probable sleep apnea. So being overweight is something that we need to look at ourselves and say to ourselves, we really should be more fit, and that will just take away another one of the possible compounding factors that's contributing to our fatigue. Next slide. Pulmonary. Patients with lung disorder, like chronic obstructive pulmonary disease, chronic persistent asthma, any sort of lung disorder which is going to impair the exchange of oxygen within the lungs needs to be looked at. So when we were doing studies with Ampligen, we were doing studies. We were doing the not only a stress test, but we were doing a pulmonary evaluation on patients who were coming in with chronic fatigue syndrome. So we need to look at not just how much or how well patients are functioning, but how well are they breathing and how well are they exchanging oxygen. And that in turn will tell us that patient's particular ability to work and to have the stamina to get through a day. Lots of patients with pulmonary disorder will have a typical body habitus, like I said before, that may be overweight. Some of them will have a history of asthma, and you want to do a pulmonary function test at least on that patient to be sure that they're not having, that their asthma is under control. So you want to do those type of things to be sure, pulmonary-wise, that they're stable. POTS, paroxysmal orthostatic tachycardia syndrome, is similar to NMH, or neuromediated hypotension, because these people's blood pressure drops. But that's where the similarity stops. The POTS patient has a elevation of their heart rate in response to changes in their position, but the heart rate is too fast. When the heart rate goes up too fast, then their heart can't continue to pump out the same amount of blood per beat, and therefore the patients feel dizzy, lightheaded, and also fatigue accompanies that. Parathyroid disease. The parathyroid gland is the gland that controls the calcium in our bodies. It controls the calcium going in and out of our bones. And the reason why I put that in here is because elevated calcium levels above 10.5 can cause fatigue and significant cognitive dysfunction. So even though we assume that people get tested when they go into the doctor and they get blood work done, even though we assume that they're getting tested for calcium, we should always be sure that that's one of the things that are being done. So elevated calcium, usually secondary to parathyroid disease, will cause fatigue and cognitive dysfunction. PMR stands for polymyalgia rheumatica, which is another autoimmune disease. This disease has fatigue as well as pain as its major component. So they'll have pain mostly in their proximal muscles, that is the upper arms and upper thighs. They have difficulty raising their arms up or raising their feet up, and they'll have fatigue, and they'll have probably usually headaches as well. The definitive way to make this diagnosis is a SED rate, easy blood test. The major confusing disease with PMR is going to be fibromyalgia. Pelvic floor dysfunction goes along with somewhat with the interstitial cystitis, in that patients with pelvic floor dysfunction will have pain in their pelvis. And this is a major component that we see a lot with fibromyalgia. The treatment for this would be mainly physical therapy. You need to find a physical therapist who understands pelvic floor dysfunction and knows how to treat it. Next slide. Rheumatoid and Raynaud's. Rheumatoid arthritis, again, is another autoimmune disease. As we all know, it presents mainly as a painful joints, usually stiffness and pain in the morning time, with some swelling in the joints as well, usually affecting the hands and the smaller joints of the body. However, again, as with all autoimmune diseases, it can present initially with fatigue, and that fatigue is usually coming from the aches and pains that people are feeling, which is interfering with their sleep at nighttime. The Raynaud's is, we see this commonly in patients with autoimmune diseases. We'll see it commonly in patients with rheumatoid. And Raynaud's is basically where the extremities, mostly the hands, become cold, and the fingers of the hands can change color when exposed to cold, either cold air or cold or ice and things like that. And the change color is usually from red to blue to white, and they're painful. But we see this a lot in the autoimmune diseases, but we can also see this a lot in patients who don't have autoimmune disease. So Raynaud's phenomenon does not necessarily have to accompany autoimmune disease, but we do see it a lot in patients with chronic fatigue syndrome. Next slide. Sleep apnea, we talked about this a little bit, in that patients with sleep apnea will definitely present with fatigue. The interesting thing is patients who have sleep apnea and you treat the sleep apnea doesn't necessarily mean your fatigue goes away. Patients who have sleep apnea, typically the patients who are overweight, they have some obstruction in their flow of air through their mouth into their lungs, usually occurs during sleep and usually occurs during REM sleep. And it wakes them up because they stop breathing. And the carbon dioxide builds up in their system, and that's what causes them to wake up to take a breath. The patient usually does not remember stopping breathing and usually does not remember waking up. So therefore, lots of times we need to depend upon the partner to tell us whether or not the patient is stopping breathing while they're snoring or not. And these people typically will snore a lot and will snore loudly. But again, treatment of sleep apnea does not necessarily mean that we're going to fix the fatigue. We don't treat sleep apnea to treat the fatigue. We don't treat sleep apnea to make people feel better. The ultimate problem with sleep apnea is that it causes a decrease in oxygenation while you're sleeping, which then causes an increase in stress on the heart, which then causes the patients to become more prone to pulmonary hypertension as well as right-sided heart failure. And that's the reason why we treat sleep apnea. The icing on the cake is that you feel better as well, but the major reason is to make sure you don't develop heart disease. Sjogren's disease, SSA, SSB, is an illness which usually it's an autoimmune disease which presents with dryness mainly. Patients will develop dry mouth and dry eyes, and they'll complain of dryness as their major complaints. However, they can also have fatigue, again, as their major, as their early onset or the early description of what's going on with their illness. I didn't put sarcoidosis in here. Sarcoidosis is another one of those pulmonary diseases, but I should mention that because sarcoidosis is it's a development of a specific type of protein that gets embedded in the tissue, mainly in the lungs, but it can affect any of the tissues of the body. In fact, it can also affect the heart. So if it affects the lungs and if it affects the heart, it will definitely cause fatigue, shortness of breath. It can cause weight loss, night sweats, definitely some coughing as well. And so it's sometimes difficult to tell what's going on because lots of times the lung exam will be normal when you listen to when the physician will listen to the lungs. Stress. Well, I have stress twice. Okay, it must be important. So obviously, stress is something that we should consider with people who are having fatigue. Why is that? Because stress is going to interfere with sleep mainly. Patients who are stressed all day, they're using energy that they normally would use for other things in their body, so therefore it's energy that is being wasted, and the end result is fatigue. And that somewhat rolls into somatoform disorders where patients are constantly worried about being sick and constantly thinking that they have something that they might not have. And that, in turn, not only creates an illness, which will be fatigue, but they are wasting energy which they can be using for better use during the day. So I always look for, and when I see a patient coming in for evaluation of fatigue, I'm always looking to see not only how you're sleeping, but also what's your job like, if you're working, or what's it like during the day, what are you doing during the day. Trying to tease out whether or not I have a patient who is significantly stressed out, which may be contributing to their fatigue. Next slide. Temporomandibular disorder used to be called TMJ, or temporomandibular joint disorder. It's been changed to TMD because it doesn't necessarily always have to do with the joint, so they changed it to be better, to be more accurate. And basically what's happening is either the muscles around the temporal mandibular joint or the joint itself that's being affected. It causes pain, irritation, inflammation, sometimes swelling. Usually the pain is when you're chewing or opening your mouth widely. The use of, how should I put this? The TMD can occur by itself, does not have to be involved or comorbid with any other condition. But we do see a lot of TMD in patients with chronic fatigue syndrome. The reason why that is, I'm not exactly sure. Maybe there is an issue going on with patients with CFS. These patients may have a significant amount of stress in their lives, and they may have a significant amount of bruxism at night. So if they're grinding their teeth, they're going to have more joint erosion because of that, and therefore they're going to create more of a problem in their temporomandibular joints. Treatment of the pain in TMD doesn't necessarily resolve the fatigue. TB, or tuberculosis, is another infectious disease that we always worry about. But these patients, besides presenting with fatigue, they'll present with weight loss, they'll present with a cough, congestion, and they'll usually have some exposure in the past. Next slide. Vulvodynia is pretty much the same thing as pelvic floor dysfunction, but vulvodynia is more specific to the pelvis and mainly to the vulva, where there's significant pain and inflammation around the vulva area as compared to the whole pelvic floor. And again, the treatment for that is exercises. The gynecologist can try some steroid creams on that, but usually that doesn't work. It usually has to do with treating the whole pain syndrome that coincides with the inflammatory process that's going on in the vulva. Vertigo is something that we do see a lot in patients with chronic fatigue syndrome. The patients, it is not one of the criteria to make the diagnosis, but the theory being behind the vertigo is not necessarily that this is an inner ear dysfunction, but more so that this is a cerebral flow dysfunction, that there is an issue with blood flow volume, and so therefore patients who have low total blood volume will see more likelihood to see dizziness, lightheadedness, and vertigo. Vitamin deficiencies, I always check for vitamin deficiencies in patients who come in with chronic fatigue syndrome. Nowadays, vitamin D is the hot topic. Vitamin D has been implicated in anything from osteoporosis to heart disease now. But vitamin D, especially women who live in the northern part of the country, have lack of sunlight exposure, and if they're not eating or drinking enough vitamin D, they're prone to having vitamin D deficiency. And I have seen patients, but mostly patients with fibromyalgia, improve when we get their vitamin D at 50 or above. Normal vitamin D level should be about 30 or 32 or above. B12 and folate, there were several studies done in the early 90s trying to figure out if IV vitamin therapy will make a big difference in patients with chronic fatigue syndrome. Those studies did not show any significant difference in patients treated with placebo versus IV vitamin B12 or folate therapy. Nevertheless, again, there are anecdotal stories about patients doing significantly better on B12 and folate infusions. Some people feel that the B12 injections or infusions should be not the cyanocobalamin, but the hydrocyanocobalamin, which you get from a compounding pharmacy. I've used it. I've given it out. I haven't done the IV infusion. I've only given the injectable ones. And patients feel somewhat better on it, but it's definitely not significantly improved. CoQ10 is an enzyme, again, another enzyme in the muscle, which we look at for muscle functionality. When we give people statin therapy for their cholesterol and they develop myalgias or muscle aches and pains, that's because the statin therapy interferes with this enzyme that's in the muscles. So the CoQ10 enzyme in the muscle gets depleted as you use these therapies for your cholesterol. And replacing CoQ10 may actually protect you against that type of muscle damage from the statin medication. They're doing a study now here in Hartford looking specifically at that to see how much CoQ10 will work, or if it does work at all, in protecting people from the statin therapy. However, because it is a muscle enzyme, the same way as carnitine, I'm curious about using it in patients with chronic fatigue syndrome, see if they can improve strength and muscle strength as well as energy with that. Next slide.
You'll see I've added some that have come in the questions. We're getting close to the end, and I have a couple kind of more general questions. But if you see anything on that list that you want to cover, go for it.
Yeah, let me talk about, let me get to the X, okay?
Okay, yep, absolutely. The big X.
The XMRV. And I understand you guys had a webinar, I think was it last one or the two?
We've had 3 on XMRV, actually.
So you beat it to death. Do I need to talk about it?
It'd be good to get, the last one I think was in August, so a few things have come out in the literature since then. So it'd be good to get your current perspective.
Okay. So XMRV is obviously everybody knows that it's a retrovirus that Dan Peterson and his group had looked at for a possible cause for chronic fatigue syndrome. He found this retrovirus in 69% of the population of patients who had chronic fatigue syndrome, and only about 3 or 4% of the patients who did not have chronic fatigue syndrome showed the virus. So it's very intriguing that so many people with the illness had it, and so many people without the illness didn't have it. Unfortunately, about 4 papers afterwards, 2 from England, 1 and 2 from Europe, did not confirm the presence of XMRV in their studies. Most recently, the paper out of the NIH said they did find a retrovirus in their study of their population with chronic fatigue syndrome, but it wasn't specific for the XMRV virus, but it was more for the general umbrella virus under which XMRV lives. So it is curious that we're finding more of this virus within the United States cohorts and not seeing this virus in the European cohorts. Also of interest is that this XMRV virus specifically was a virus that was discovered about 5 years ago in patients with prostate cancer. So the question was, at that time, is this virus implicated in the development of prostate cancer? Which then opens up the other category of possibilities as if this virus is implicated in the development of prostate cancer, is it implicated in development of chronic fatigue syndrome, and therefore is it implicated in developing of the malignancies that are associated with chronic fatigue syndrome? So it's never-ending questions with this, and unfortunately there's no answers to any of the questions I just posed. But research is still ongoing with this particular group of viruses. And what I would caution people, however, is that you'll see a lot of things on the web about these places claiming that they can test for XMRV and things like that. And I would be very cautious in looking at and doing that, because if the labs and research labs in Europe and the research labs are in our country are having difficulty replicating and finding these viruses, a laboratory which is not a research lab and was in it just for the money may be may not be 100% kosher. So I'd be careful about that, about just going off and sending your blood out to any lab that said that they do it. So let's see. Mold exposure. Mold exposure has been another one of those hot topics, and I think I would categorize it under the multi-chemical sensitivity exposure, in that these patients do become ill in an environment which is basically toxic to the patient. I have seen patients who've had significant amount of mold exposure, and in fact, I would say even in my own household, at one time there was a significant amount of mold, and my wife was starting to become ill, so we had to really gut it and get that out. So definitely, it is a risk factor for developing chronic fatigue, but I think it has to do with the amount of exposure and the amount of time that you're exposed to it, after which there may be a point of no return. I'm not sure why we put osteoporosis in there. I really haven't seen an association with osteoporosis in patients with chronic fatigue syndrome, except to say that patients who are immobile are at a higher risk to develop osteoporosis because of depletion of calcium from their bones. Post-exertional relapse, that is one of the criteria. I wouldn't put it as a separate comorbid illness. It's a criteria for chronic fatigue syndrome. So I always ask my patients, if you overdo it on one day, do you pay for it for the next 2 or 3 days? And if the answer is yes, that goes to one of the categories that I check off. So okay, just post-exertional malaise is what I would call it.
The reason I added it on the list there was several questions, and it's come up and been a topic of a lot of recent discussion, is whether post-exertional relapse helps you as a physician sort through whether your patient has CFS or some other condition, whether you find that to be a characteristic symptom in both the diagnosis and sort of following your patient over time.
Absolutely. Absolutely, and I use that as a one in my questionnaires. Absolutely.
Great. You know, a lot of these came in, and I know there's tremendous interest. There are probably 3 times as many more I could have put on a list that came in while you've been talking. But if I may take the chair's prerogative for our last 2 minutes, how do you help your patients sort out when they've been diagnosed with CFS and have new symptoms arise, whether that's just part of their disease or whether that might be something new occurring in the context of CFS?
The CFS is an illness where you develop the illness, you make the diagnosis of the illness, and it usually doesn't change. If it changes, then it should be a red flag and a trigger to pursue either the rework of the diagnosis and also to pursue the reason for the change. It may be part of the chronic fatigue syndrome process or development, if you will, but it shouldn't be a significant change from your original diagnosis. And if it is, it deserves a second look.
And so as people age with CFS, and there are disease, conditions that are very common as we age, like diabetes and cardiovascular issues, do you see that people with CFS are more susceptible to those conditions, or do they occur at about the same rate as your other patients in your internal medicine practice?
So and that's a good point. So as people age, just because you have chronic fatigue syndrome doesn't mean you can't get anything else. So obviously, if you're seeing your physician, it's not just for CFS. You go in there for your regular checkups. You go in there, you're going to look at your heart. You're going to look at your lungs. You're going to do all these things. As far as CFS patients developing more of one particular comorbidity than another, I haven't really seen that unless the patient is doing something or not doing something that puts them in a higher risk. For example, obviously if they're not exercising, they're going to be at higher risk to gaining weight. You gain weight, you're higher risk for insulin resistance. That puts you at higher risk for diabetes. And if you're not doing much of anything, it puts you at higher risk for osteoporosis. And if you're not maintaining any sense of conditioning, it's going to put you at higher risk of heart disease. So in that respect, I think CFS poses a risk as people get older.
And that tends to track what we hear from, directly from patients, that these other conditions sort of layer on top of their CFS symptoms and complicate management and, function and quality of life over time, unfortunately.
That's why you can't just always blame it on the CFS. And, it's always, the better example is a patient with fibromyalgia. Every pain that they have, they blame on fibromyalgia, and then they blame their chest pain on fibromyalgia, and they have a heart attack. So you got to be careful.
Great. Well, we have exceeded our time. We still have a huge audience online that have obviously hung in there to listen to you move through the alphabet, and it was really sort of a fascinating tour of internal medicine, I think, the way that you wove in so many body systems and conditions and symptoms that are both common in CFS and not as frequent, but should be sort of telltale signs to pursue perhaps additional testing or consider other treatment options. So thank you. That was tremendous.
Well, thanks for having me. Just shout out to everybody in Chicago if they're on the line.
Yep, several patients actually wrote in that they were glad to hear you again. They were your patients in Chicago and look forward to hearing your voice again. If I could just take a minute here to let people know about the upcoming webinars we have. On November 11th, we'll have Dr. Lucinda Bateman back for her third webinar. So she's become sort of a alumnus of our webinar series, talking about how to communicate with your healthcare professional. And we get many questions, no matter what the topic is, about how to find a doctor in your local area. So this will be, I think, a great topic for people who are trying to find a local physician to provide sort of primary care for their condition. And then as we move into the holiday season, we have Dr. Bruce Campbell and Dane Cook, who's an exercise physiologist, kind of approaching the pacing yourself through the holidays topic from different angles. Dr. Campbell has developed an online sort of self-learning module to help people improve their function and manage their energy, and Dr. Cook is expert in the objective measures of how to pace energy and measure exercise physiology. So that should be an interesting topic. And then on December 2nd, we have Dr. Gail Ironson from University of Miami sharing some ideas about spirituality and health with us, and that will conclude our series for the year with, I think, a total of 18 programs. So we look forward to having many of you back for that. And just as a reminder, here are some links. We'll send out an email after the webinar to let you know where to find the recording of today's program and also the slides. And here are some other helpful links that you may want to track down after this. And there were many questions that came in about the topic of early mediated hypertension, postural orthostatic tachycardia syndrome, POTS. So I'll make sure that the follow-up email also includes links back to Dr. Rowe's seminar, and also we had Dr. Meadow on talking about those topics from a research perspective. And then just a reminder, the association's mission for CFS to be widely understood, diagnosable, curable, and preventable, and our strategy to expand the research and stimulate public, private, and commercial investment in CFS. And so we hope that if these webinars are valuable to you and the information we provide, you'll support the association. We're in the midst of our annual fund campaign that will help us continue being here to help you. And we thank you for your participation, and thank you again, Dr. Papernik. I look forward to putting these materials up so that they can reach this audience and a broader audience as well. So with that, we'll sign off and hope everyone has a pleasant afternoon or evening, depending on where you are, and a great day. Thanks so much. Bye-bye.